So as I told, the aphasia is a disorder of language. So as to define language, it is an a way of communication. How can we communicate? Through two ways, like visual and verbal also. Visually by words, even by symbols. This is what the definition of a language is. Like, it is a way of communication. It is a complex way of communication with visual plus verbal uh, uh, parts are involved, and within visual, both words and symbols can be used to communicate. So aphasia is a disorder of language. As a whole, like, disorder of speech includes aphasia or dysphasia, dysarthria. Dysarthria is disorder, means there is disorder of articulation. And dysphonia is the voice is itself not produced. So first we'll study the common language pathway. So in the language pathway, first imagine, like, we are showing, we are asking a patient to repeat it as a pen. Like, we are showing the pen to him and asking him to identify what is it. So what all the process undergoes, and just simultaneously I'll explain this another symbol also. So both the information will be received to the through eye to the visual cortex. So visual cortex performs three functions. So what are the three functions which it performs? First, it receives the both the pen it will receive, and then a dysmorphic face, it has received a signal. So then it will analyze. What would all it will analyze? How much is the shape? What are the length? How much length it is? All this will be interpreted. Then it will report. Okay, this is it will not identify till now as pen. Okay, this is in shape. This information, then it will give it to the dictionary of the brain. And the dictionary of the brain is Wernicke's area. It is over the just over the auditory area near the gyrus. So this constitute the Broadband area. 44 and 45. So whenever this information will be received by the dictionary, so it will identify it as a pen. Okay, we showed it another symbol also. It will identify as an abnormal shape is there, which it will not be able to interpret. Then this information will be carried from Wernicke's area to the Broca's areas by arcuate fasciculus. And important function of this fasciculus is like repetition. We will come to that part also. So what does this Broca's area do? Like, we have asked the patient to identify pen. So first the patient has received from the visual cortex, then to the dictionary of the brain, that is Wernicke's area. Then it in the dictionary it will identify it as a pen. So we have just showed the image. Now the patient function is to tell what it is. Like, he should identify it as a pen. Now he has identified as pen in the Wernicke's area only. And identifying this kind of means it carries this information from the childhood. It all the memories, all, even that part also is involved. Even the limbic part also is involved for this identification. So the first it will identify it as pen, then it will transmit to the Broca's area. Okay, this is a pen. So now the patient has to tell it as a pen. Now what parts are involved in the from the Broca's area? It will communicate to the parietal areas, sorry, the frontal areas. And the Broca's area receive information from the two other sides also. Like from the visual directly, it goes to the cerebellum also, one pathway. then it will give information to the Broca's. So what there is intercommunication between this. The cerebellum will help us to tell how it has a pen. Like it will give a blueprint how to say it as a pen. Then accordingly, it will communicate with the frontal area. In the lips part is there. In the face part, in the homunculus, the face part will be there. So it will identify what to be told. So what muscles are involved, how much force has to be told, how loud has to be told. All this information, it will be carried out from the frontal cortex. And this is an upper motor neuron. From the upper motor neuron, then it will carry the information to the medulla and the lower pons. So what it contains, mainly this cranial nerve nuclei, 7, 9, 10, 11, and 12. So these nuclei are involved. From the upper motor neuron, then it will transmit it to the particular cranial nerves. It identifies it as it receives the information from the upper motor neuron. Then accordingly, it will perform the function. Like seventh nerve will supply the lips part. So it will supply the lips part here. The ninth and 10th cranial nerves will supply the pharyngeal walls, and that ninth will supply the soft palate here in the palatal region. It also supplies the pharyngeal part, and the 10th and 11th cranial nerves will also help supply the both the trachea and the vocal cords here, and the 12th cranial nerve will supply the muscles of the tongue. So this part, so till now, wherever the part it is involved, here we call it as aphasia. From here we call it as, if it is affected, then we call it as dysarthria. So what are the various types of dysarthria according to this? So if the information from the upper motor neuron can be carried out to the lower motor neuron, two pathways. First it will go to the basal ganglia also, and basal ganglia also will send the information to the cranial nerves to various pathways, and even cerebellum also will send the information to the directly to this also. So directly it gives an information to the upper motor. It will use a blueprint how to say it as pen, and also the upper motor neuron will fire that much amount of neurons only, and specifically what muscles has to be activated. So then it will the patient will say as pen. And we had showed in another dysmorphic phase that the patient will be not be able to identify. So we had shown this shape, like the patient will not be able to interpret, because in the Wernicke's areas it has not been feeded before. So then the patient will not be able to comprehend or tell what it is at all. So this is the language pathway involved. From the eyes, it goes to the visual cortex. The Wernicke's areas, the dictionary also receives the information from the auditory also. So even if you tell it as pen, if you ask the patient to repeat it as pen, means the patient has to repeat. So the auditory information will give information to the Wernicke's. When you say it as pen, the patient image also will be formed, and these all things happen in the Wernicke's area. It's like a dictionary. When you say it as a pen, the patient will identify it as a, okay, this is the pen. Like now he has to repeat now. Then the same path will continue. Even if you give the patient the sensory stimulus, like if you give asking the patient to close his hand and asking him to identify the object, then when you give the pen also, this information also from the sensory part, it will be traveled to the Wernicke's area. So then also the patient will be able to identify what it is. This is the help of the Wernicke's area. So then with the arcuate fibers, then to Broca's area. Broca's area is present in the inferior frontal gyrus, and it is in the posterior part of the inferior frontal gyrus. Then the particular, it will coordinate with the upper motor neuron. Accordingly, this will send the signals to this. So this is about the language pathway. So we'll see what are the different definitions of this. So aphasia is, as we heard, as we studied, that it is a disorder of language. Dysarthria is there is difficulty in articulation. Dysphonia is even for the production of sound, the patient will produce sound during expiration only, and that coordinated movement of the vocal cords will happen. That is carried out by the particular lower motor neurons also, and even from the and how much amount of air has to be expelled out from the lung so as to produce the sound, and what are the pharyngeal muscles should be contracted, and what are the tongue muscles should be contracted to produce to say it as a pen. Next, coming to the definition of alexia, patient here is unable to read. Like if you show him it as a write it and show it as a pen, like the patient will not be able to read. Agraphia is the patient is inability to write whatever you show. Paraphasia, like the patient, if you show it as a pen, patient will paraphasia means here the patient will not correctly interpret it as a pen. Patient might say it as pencil, or patient might say it as, not because of the visual dysmorphic features, but just in giving an example, that patient will not absolutely tell what it is, but he will come closer to that, and whatever close he comes, the syllabi might be changed. Like pen, he might say it as hen, but the desired response will not be obtained. So what are the parts of the speech analysis? So what all things we'll analyze during if the patient has aphasia? First, we'll check the fluency. How we'll check the fluency is like we'll ask the patient to speak by himself, like try to tell, is it fluent? If he is speaking fluently or non-fluent, then we'll identify. Next, the speech analysis comprises 6 parts, and important is the first 5 parts, and within that 3 are very important. That is fluency, another is repetition, and third one is comprehension. So whenever the patient has aphasia, will go ahead with discussing with under these headings only. First, will comprehension, how we'll assess is like they will ask the patient like you will ask him to follow series of commands, like take the pen and keep it on the table, or ask him to stick out the tongue, and ask himself to hold your thumb. So all these commands you will be able to comprehend through the Wernicke's area. Okay, he has asked me to for hold his tongue, stick out his tongue. Then the patient will accordingly will bring out the tongue. If he is asked to perform a motor task also, he'll able to do particular thing by analyzing what he has said. So next, under this also repetition. So particular information whenever we give, we ask the patient to repeat by himself. Like if we say as pen and ask him to repeat that thing, so how long he is able to repeat, that we'll be analyzing. A is associated signs, which we'll be discussing the subsequent aphasia types at last. N is naming, like naming what objects. Like if we give the pen, he should be able to identify it as a pen, and he should be able to tell what type of pen it is, blue color, black color, or if label the parts also, like pen cap, refill, all those things has to be told. So this constitute the parts of the speech analysis. Next, coming to the first variety of the aphasia, like the patient here has received the information from the Wernicke's, from the arcuate fibers, then it will receive to the Broca's aphasia. So as a whole, to simplify the things, like Wernicke's area is a region where it will perform the comprehension. It's like whenever you give the motor task, it will comprehend what to do the thing, and it will receive information from visual pathway, from auditory pathway, from sensory pathway also, and even from the touch also. Then the arcuate fibers is concerned with carrying the information from Wernicke's area to the Broca's area, and this is concerned with repetition. Like how this helps in causing repetition is not known. Means these particular neurons or the particular neurons were undergoing activity during when it was analyzed. And Broca's will bring out the particular speech output. Means it helps in the speech output with the help of the upper motor neuron from the from the frontal cortex, from the basal ganglia and cerebellar, whatever the information which is receiving, it will coordinate so that it will perform that. So the patient here is having Broca's aphasia. Broca's aphasia is like the patient is not able to speak now. Now this patient is not able to speak. So the patient, if you put this mnemonic here, like the patient is not able to perform the motor task. It is non-fluent speech, and it is telegraphic speech. Like the patient faces difficulty to perform the particular motor, like tell it as a pen, or if you give him a sentence, he will not be able to tell in a complete sentence. Rather like a telegram. If you give like keep the pen on the table, means he will be able to tell, he will omit all the verbs and tell it as like pen, table, the whole that's why it is called as telegraphic speech. And even the patient here, the comprehension part will be intact. Here the patient repetition also will be affected. Even in the Wernicke's area also, the particular repetition part also will be affected here. So it is affected. Comprehension is intact. The patient is unable to name because the speech output is only poor, means the naming also will be poor with respect to the verbal. But he is able to understand whatever the information is given. And whenever we ask the patient to write, the patient will not be able to write completely. Like it will be like dysmorphic handwriting. Like patient will have like to write it as pen, he will not be able to write it as properly as pen. Because it could be due to two reasons. Like the patient is not able to perform the task because of the affected Broca's areas. And even usually one concept is there, the dominant hemisphere. So left sided will control the right sided in the majority, and even in the right side around 70% the dominant hemisphere is the left side. So this is what the concept is. Like usually whenever the patient has aphasia, the middle cerebral artery of the left side will be affected. So that's why whenever this is involved, the right sided, the patient will be having right sided weakness, right sided along with that patient will be having unable to perform means the sensory deficit also will be there. So both motor plus sensory deficit will be there, and patient will be having these symptoms. So another important is like the patient will be having depression. Why these patients will have depression? Because the patient, whenever he's conscious that he's able to comprehend all the things, but he's not unable to say that. That's why the patient usually will be depressed. This is about the Broca's aphasia. Like Wernicke's aphasia, like the patient is not able to comprehend the things. And even here, so the motor output is normal here. So what happens to the fluency? The fluency will be normal. Means the patient is actually it is the patient will have logoria, like you'll continuously speak, and even neologisms will be seen. Like you'll try to introduce new words. All this will be seen, and sometimes paraphasia is also seen. Like he might be telling pen as hen, or pen as something else like pencil. These things also will be seen. So the patient, whenever he showed the image of pen to him, he was not able to understand what it is. So rather he will not be able to understand, rather he'll speak fluently but will not tell correctly it has pen. And what happens to the comprehension? It is significantly affected here. And even the repetition part also is affected in Wernicke's area. So that's why I'm underlining both the Wernicke's area and the area near the arcuate fibers. what happens to the associated sign? Here we had studied like it is near the temporal superior temporal gyrus. So here usually the motor deficit and sensory deficit will not be seen, as which we seen in the Broca's aphasia. And coming to the naming also here it is affected. Like the paraphasic substitution will be there. What happens to the writing? The patient handwriting will be neat because the motor part is not affected here. This is about Wernicke's aphasia. Difference is like Wernicke's and Broca's, the area which is affected, and significant difference is like the comprehension will be normal in Broca's, it will be affected in Wernicke's, and whereas the speech output or the performing the act, it will be affected in Broca's, whereas patient will not be able to understand, but he will able to be perform. Like if you give the pen, he will able to write, but he will not be able to write what you say. Coming to the conduction aphasia, here the only the arcuate fibers are affected. So then the patient will have defect only in the repetition. So the repetition part will be affected. The rest, the patient, if you ask the patient to perform a motor act, he will be able to perform. But that this alone doesn't signify that there is no complete disconnection between Broca's or Wernicke's. As a whole, it will not happen. But the patient will not be able to repeat whatever you say. So where are the conduction aphasias we will see? It is seen in when there is a lesion. Like arcuate fibers will go from the temporal to frontal part by like in this shape. Like any part might be affected, still the other part might be normal. So as a whole, affection of the whole of the arcuate fibers won't happen. So the conduction aphasias, that's why the repetition part only is affected. Rest, the fluency will be maintained, patient comprehension will be there, patient is able to read and even write also. Even sometimes like naming might be affected or not, like it would be normal also. Coming to the global aphasia, like the patient here will be having complete involvement of both Wernicke's area, arcuate fibers, and the Broca's aphasia. Like what happens to the fluency is it is affected, and what happens to the repetition, even this is affected, even the comprehension will be affected. What will be the associated sign? Like significant motor weakness will be there, significant sensory weakness also will be, you'll be noticing, because the patient sensory symptoms also will be noticed, because the patient to involve such a large area means he should have a large vascular stroke. Where does it occur? Like if the stem of the middle cerebral artery before dividing into upper part and lower division, if the stem only it is affected, then whole of the supply of the middle cerebral territory will be affected. This is about global aphasia. Next is cortical aphasia. Like here the language areas will not be will be affected. The important difference is like the circuit will here will be maintained. That's why the repetition will be normal in this patient. So what happens in the transcortical area is like it is of three varieties: motor, sensory, and mixed type. Like we'll discuss each of that. First one is the transcortical sensory. Like sensory part is affected, the Wernicke's area is affected, and the sensory association area is affected. But the path will be normal, so the repetition will be normal, fluency will be affected, naming also will be affected, and even the reading also will be affected here. What happens to the comprehension? Even this will be affected because both the Wernicke's and the associated sensory cortex part is involved, because the patient will not be able to get the information from the sensory association area. Like this is the part where it will do other two functions. Like I had discussed three functions. First one is receiving, then analyzing, then lastly reporting. So in these two functions will be done by the sensory association area, and this information will not be given to Wernicke's area. That's why comprehension also will be affected here. This is about transcortical sensory. Next, coming to the transcortical motor. So the Broca's area is affected, and associated sensory part is affected. Motor part is affected.
So, in sensory cortical aphasia, fluency will be affected.
Sensory cortical aphasia. Ha, ma'am. Fluency will be affected here.
Okay, so if comprehension is also affected, fluency is also it's non-fluent. How can repetition be normal?
Ma'am, like the repetition part.
Like we are saying, no, the
Ha,
patient
ma'am. I
is not
understood.
able.
Like how the patient will be able to repeat the things. Okay, the one difference is like the arcuate fibers is not involved here, but whatever the information he is receiving, he is able to repeat whatever the information he is having. Like he will not be able to tell whatever you are saying. I mean, if you tell the patient has pen, he'll not be able to tell it as pens. He will tell pencil, but if we ask to repeat, he'll tell as pencil only repeated. So this part is not affected. So how where these kind of symptoms are affected, like when there is involvement of the middle cerebral artery, but the sensory affect, but the whole of the Wernicke's and the arcuate fibers are not involved. So the repetition part is only where the patient is able to repeat by himself or something. It's not necessary that patient has to tell that whatever we are saying.
Okay, thank you.
In the motor part, ma'am, like both Broca's will be affected. So to give an example, if the lesion is anterior to the Broca's aphasia, here is the Broca's aphasia, like any lesion is here. So only this, if there is stroke involved in the middle cerebral artery, if in this particular territory, if it is involved, Broca's information will not be correctly will be means able to be performed by that, but the patients is able to perform the comprehension will be normal. The fluency here also will be affected because it has to coordinate with the particular neurons also to produce particular fluent sound, fluency in speech. So that is affected. That's why the patient will not be able to perform this. And with respect to the repetition, it will be normal. All transcortical aphasias, the repetition is normal. And another here also the naming, the part will be here also, it will be affected. Like the patient will not be able to tell whatever it is. And associated signs will discuss later, like what whichever the territory is involved, particular symptoms will be there. Coming to the mixed variety is like it is very unlikely to occur. Like here the patient, only the sensory affected area, sensory association area and the Wernicke's area will be affected, and the Broca's motor association area is affected. So in this variety, like the patient here also, the repetition is normal, rest the fluency is affected, the patient is not able to comprehend, and patient naming also is affected. Like where can this occur? Like if the patient is having stroke in multiple regions, could be one possibility, but leaving behind both the Broca's aphasias and Wernicke's aphasia is usually unlikely. This kind of occurrence of mixed transcortical aphasia is a bit rare. Coming to the subcortical aphasia. So there is a concept of the thalamus also helps in the language. How does it helps in the language is like so thalamus as in ventral anterior lateral nucleus. So this in thalamic affected patient, like when the thalamus is affected by stroke or something, usually the tubero median artery will be affected. So the associated language cortex means what does it give? Does it like it gives information even to the sensory Wernicke's area? What happens here is like the patient, one phenomenon is noticed, like one, like if the patient sensory part is affected, still the patient fluency will be there, not maintained, comprehension will be maintained. What it was noticed, like the patient, when you has two states, like when the patient is in drowsy state, when it is significantly affected, the patient mumbles here, like, and the comprehension is poor. And when the patient is in alert state, where the thalamic is also affected, the patient can have normal language. Why this difference was observed in thalamic aphasia is like the this thalamus is like an act. One concept that what they are told is like it alerts the language cortex. Uh, so that's why there is this difference is noticed. Otherwise, the patient can have normal comprehension also, normal repetition also, normal reading also, and the naming also will be normal in thalamic. Like the dual also is noticed. Like even the comprehension might be affected here. Why this was affected? Like the when the patient was simultaneously was having drowsiness. So this concept is there. Like uh, if the patient is having thalamic part, then cortical, the comprehension part will be still intact majority of the times, but still it can be affected in some states. Coming to the basal ganglia, so what happens is, like, to initiate speech and to stop the speech, we need basal ganglia. Like this performs like an in this similar activity compared to the means whatever motor activity. It takes the initiation, it will give particular tone also, it is responsible for stopping up the particular movement also, it helps in the smoothing of the movement. So this basal ganglia, when it is affected, and important nuclei which are involved in the language cortex is like caudate and putamen. So in putamen, we know that like it is the most common site for intracerebral hemorrhage. Uh, like the putamen in the anterior aspect is associated with the internal capsule here. The posterior part is there, and simultaneously caudate nucleus is there. So what happens? What one has noticed, like even the basal ganglia lesions can have speech disorders. And when what kind of speech disorders can it can produce? Like here, the patient, if the posterior part of the putamen is involved, even the posterior limb of the capsule is involved, internal capsule is involved, then the patient can have like resemble like Wernicke's. This kind of feature was seen when the basal ganglia was affected in the posterior aspect, like posterior part of the posterior limb of internal capsule and posterior part of putamen, and the deep white matter temporal cortex associated with that. And simultaneously in the basal ganglia of in the anterior aspect, along with the adjacent putamen, when it is affected, anterior limb of internal capsule, like the patient had dysarthria kind of symptoms. And when whole of this both anterior and posterior part of the subcortical region involving basal ganglia and adjacent cortex part, white matter also is affected. So it produce like a global aphasia. Like how to differentiate like Wernicke's, Broca's, and even global aphasia from these basal ganglia lesions is like the patient will be having simultaneous basal ganglia symptoms, like extrapyramidal symptoms will be seen. So that has to be noticed. during examination. Next is anomalous aphasia. So some patient is able to tell, if you show the image of pen, he is able to tell we write with this. So he is not able to tell what it is. So this kind of phenomenon was seen in anomalous aphasia. And what is the lesion involved here is like, prior to coming to the Wernicke's area, the sensory part might be affected. So that's why it can produce anomalous aphasia. One phenomenon was seen, uh, and this resulted in like anomalous aphasia. Next is pure word deafness. When there is only involvement of the Broca's areas alone, where surrounding the white matter cortex is paired, only there is isolated involvement of the Broca's area, then pure word deafness is noted. Like the patient fluency is affected, rest all will be normal. Repetition is able to uh, repetition will be the associated symptoms might not be seen. The patient naming will be normal. It is affected in fluency. When it is affected fluency, along with that naming also might be affected, and along with that patient will have comprehension which is normal. What is like the patient other associated symptoms will not be seen, like only Broca's aphasia will in this. Next variety is like ephemia. Ephemia is a terminology, it is a variant of like the patient here also sorry I okay, this variety is aphemia. The pure word deafness, I will tell it as pure word deafness means patient whenever you give the word, the patient is not able to understand the word. Means that's why only the Wernicke's area, when it is affected, then it is called as pure word aphasia. Aphemia is like the patient when the only isolated Broca's area is affected. Next terminology is alexia. Alexia is inability to write, and it has two various syndromes. Like first syndrome is associated with agraphia, and another syndrome is associated with without agraphia. So what happens here is, means the patient is able to write here, but is unable to read. So what happens here, the patient is fluent here, he can speak, he can repeat also, but especially association will come at last, but the patient naming would be difficult, is unable to read it there. The comprehension also will be normal. Then where is the lesion here it is affected is, so the particular information whenever it is received from the cortex, it gives the visual cortex give information to the particular Wernicke's area. When the region here, like this is in the when the region of the splenium is affected, like these fibers are not transmitted, so the patient is able to see it but not able to tell read what it is, but the patient writing ability will be normal. Like the if you ask the patient to uh, means without agraphia is like the writing part will not be affected here. Like if you show him tell him it as pen, uh, like through verbally he will be able to write that, but when you show it as a pen, like the patient will not be able to identify it as pen, but he can write it as pen. Like what here where it is affected is the, like whenever the information is received bilaterally, there will be sending the information. So another part will be normal, so the patient will be able to tell, still it has write it as a pen. What happens without with agraphia is like the patient is having acquired illiteracy, so patient cannot read, cannot write. What happens to the fluency, like where the lesion is affected here, here is like just above the near the Broca's area, in the inferior parietal lobule, inferior in the angular gyrus, like the patient which is supplied by MCA, like this area is where the patient will be able to like when you ask them to tell the information from the means when you ask him to write, actually like he will be like first we'll discuss the frank, like the fluency here it is not affected, uh, and even the comprehension part is not affected. Only the patient is not able to read here and not able to write here. How it is affecting is like it was seen in the lesions where in the inferior parietal lobe. One concept is like the if uh, when you give the information through auditory, the patient is able to actually identify it as pen. So associated with the Wernicke's areas, the sensory area which when it is affected, the like the patient will not be able to write at all, like he'll be, there will be impairment. uh, I'll clear out the concept once again like later. So as a whole, approach to aphasia is like, first we have to identify it as aphasia, then we have to differentiate between dysarthria, like there is difficulty in articulation will be, has to be differentiated from the aphasias. So it is a even in dysarthria also the patient UML lesion can be affected, LML lesion can be affected, cerebellar lesion can also lead to dysphagia, dysarthria, if that nerve when it is affected, or when when there is neuromuscular junction abnormality, when the muscle abnormality is there. So any of these things can produce dysarthria. Example is like in muscle OPMD can affect, like oculopharyngeal muscular dystrophy can lead to this kind of dysphagia. Neuromuscular junction, some patient will have pharyngeal symptoms also, like myasthenia gravis patient having uh, pharyngeal symptoms also, dysarthria. So why it is occurring? Because all the soft palate is also is necessary, pharyngeal muscles also is necessary, tongue is also necessary, and lips is also necessary to produce proper sound. If any one of that is affected, means it will lead to dysarthria. And UMN lesions, like it can be due to motor neuron disease. LMN lesion, even it is due to motor neuron disease. And cerebellar, like whenever the patient here, dysarthria, why it is produced, like the patient here uh, is able to tell it, but not in a proper way. There is incoordinated speech. What do you mean by like incoordinated speech? Patient will burst out with sometimes burst out, sometimes he'll tell very slowly, or patient will scan each letter and tell it as speech. And these all things can be there. So after ruling out this, and even we have to rule out phonic causes, like all the muscles from the, so To produce a phonation, we need a proper expiration. The respiratory muscles also must be normal. The particular trachea and also should be normal, and the vocal cord also should be normal. All these are necessary. Like to produce a proper speech, aphasia means phasia and articulation and phonation. All the three are necessary. So we have to identify which type it is involved, like based on the associated symptoms. Uh, After that, we have to rule out what there is a terminology called apraxia to speech to differentiate between apraxia speech and aphasia. Like how do you differentiate this? The patient is unable to perform an motor act is called as apraxia. Uh, like how to differentiate that there is aphasia and apraxia. Like here, when you tell him to perform any function, ask him to keep him the pen on the table. Like which aphasia we oftenly get confused is like with the Broca's aphasia we often get confused with the apraxia. Why? Because the motor act is affected in both. So how do you differentiate in this? Is like if you ask the patient yes or no type of questions, then he will in the apraxia still he will be not able to perform. Like if you ask the patient, do you get repeated vomiting, he will be tell at least he will be able to comprehend, tell that it is no. And if you give multiple like close the pen cap and keep it on the table means the patient will be able to perform that. Whereas apraxia, the patient will be not able to perform. How to differentiate an apraxia with Wernicke's? Both the motor effect is affected and the same Wernicke's like comprehension is affected. If you tell the patient to perform the close the pen cap and keep it on the table, both will not be able to tell. Here also what differentiate is like the associated symptoms only. Like comprehension will be affected, the comprehension will not be affected usually in apraxia. Patient will able to understand that, but he will not be able to perform that. So after ruling out means what type of aphasia, even the psychiatric causes like uh, any disorders of thoughts like schizophrenia, all those things, like the patient will be able to produce new words like neologisms will be there, will start producing different words. That's why it is able to differentiate means these all these things has to be differentiated to call it as aphasia. Then what are the prerequisites required? There are 5 points. Like the level of consciousness is important. Which handed is the patient, right handed or left handed, which we have to see. What is the mother tongue of the patient, means which language he speaks, uh, which it is necessary. Is he deaf or not, is he blind or not? So all these 5 prerequisites is has to be noted before identifying various type of aphasia. Like before performing aphasia test, like what these 5 things should be assessed. Like what is the level of consciousness, all these things has to be assessed. Then after this then you will go to the as a whole. I'll summarize them now. Like whenever you haven't identified it as aphasia, you are differentiated from apraxia and uh, dysarthria and dysphonia, all those things. And first you'll check is the fluency. If the fluency is intact, it will be not intact, non-fluent. Non-fluent type is the motor part is affected, right? Then what kind of motor is affected? Then we'll do repetition. We have both motor na, like the patient is having Broca's also, transcortical motor also. Both will be having non-fluent speech and even global aphasia also will be having non-fluent speech. Even mixed transcortical, even these patients also will be having non-fluent speech. How to differentiate this? Then we use the next step, repetition. What happens to the repetition in the Broca aphasia? Like uh, here it is affected though, and even in the global it is affected. What happens to the repetition in the transcortical part? In the motor, it will be intact. What happens to the mixed transcortical also? It will be intact. Then we will be able to differentiate. How to differentiate these two then? And then we have to do comprehension test. Then we will be able to differentiate. In the transcortical motor, comprehension will be normal. Transcortical mixed, the comprehension will be affected. Then how to differentiate Broca's and global? So both having non-fluent speech, both the repetition part is like affected because of the decreased output only. Then we do it then the same step here, the comprehension. It will be intact in Broca's majority of the times. One concept is like even the comprehension might be affected in the Broca's aphasia. How, like if you give him a simple task like to identify it as a pen, he might be able to identify it as a pen. When you give a complex task like to identify in a complex sentence, then he will be able to not able to completely comprehend properly. Even that might be seen in Broca's aphasia. One concept which can be seen, like it is, there is no hard and fast rule like to rule out even in the transcortical, which I told, like even the repetition part might be affected here. Sorry, the repetition will be intact, like sorry, not this in the global aphasia, like the comprehension part will be affected here. So in this identifying the step, first three words are important: F, R, and C. Fluency will check, repetition will check, and comprehension will check. Next, coming to the fluent aphasias. Here, again the same. The patient will check. The next step is repetition. What happens to the repetition? If the repetition is poor, two causes will be there. One, Wernicke's. Another is conduction. If it is good, then transcortical, sensory, and another one is anomic aphasia. Then next step we apply is comprehension. What happens in the Wernicke's? Like it will be significantly affected. What happens in the conduction type? Only the arcuate fibers are involved here. So that's why the comprehension will be normal in this. What happens in the to differentiate the anomic aphasia and the transcortical aphasia? When we apply the comprehension test, like we'll ask the patient to perform the multiple motor tasks, the patient will be able to perform in good in the anomic aphasia. Like the Wernicke's area is spared here, whereas transcortical sensory the comprehension will be poor. So after identifying is it has a various type of aphasia, like what are the syndromes we commonly face? Like this aphasia syndromes is associated with various causes, like vascular causes, most commonly with stroke, and most commonly with embolic or thrombotic and associated hemorrhage also. If the patient is having stroke in the MCA stem only, then the patient will have global aphasia. Then the MCA will be dividing into upper part and the lower part. when the upper part is affected, then what kind of like in the superior region, upper Broca's areas might be affected in the MCA. The Broca's might be affected. In the inferior part also, it will further go inside and divide into the lower part. Even this part is involved, then it is inferior division of MCA which is affected. Then the patient can have wernicke's like aphasia, or associated auditory complex also will be affected. And sometimes if anterior cerebral artery is affected, then the patient can have symptoms means the deep matter is involved, but within the not the Broca's area will not be affected here. So the anterior to the region and deep within the frontal cortex, when the lesions are there, the patient can have transcortical motor aphasia. And the second, to rule out how to differentiate there will be progressive aphasias in tumors, in degenerative diseases, and frontotemporal dementia, Alzheimer's disease. All this will have this progressive aphasias. And even patient having infection can have aphasia. Like one case was there, like in HSV, it affects the temporal lobe, and particularly it can involve the and orbitofrontal cortex also. So that's why the patient might develop aphasia here. And the aphasia is an important sequelae of the herpes simplex encephalitis. Whenever the patient is recovered from that, usually the patient will be having aphasia. So to summarize, like we discussed various types of definitions. We discussed what are the types of aphasias. Under that, 4 common is like Broca's, Wernicke's, conduction aphasia, and global aphasia. Under that, we still discuss 3 parts under transcortical, sensory, motor, and mixed type. And still other 2 types were like subcortical, when the patient is having thalamic, when it is affected, and the basal ganglia is affected. And under the basal ganglia, the anterior part of the basal ganglia and the posterior part of basal ganglia is affected, and both of the basal ganglia is affected. And some syndromes like alexia with agraphia and without agraphia. These are the various types of aphasia we have seen. And leaving that, special types were 3, like anomic, pure word and aphasia. Like this completes as a whole as aphasia. Sir, how to differentiate? Okay. I'll try to cover this part also, sir. Like cranial loss, I'll try to divide into 3 topics. Means to cover both all the cranial loss, it will take some time, sir. I'll try to cover anatomy and both the correlated part.
यार सब नहीं चाहिए यार, वो जो इम्पोर्टेंट वाला वही कवर कर लेना, जो
Okay,
7 है,
okay, okay.
2
ठीक
है
है.
ना.
Just anatomy and testing would be good, I think.
सुजीत,
Okay,
सबका
sir.
एनाटॉमी चाहिए होता है क्या?
नहीं, सबका anatomy नहीं, anatomy of important ones and then testing सबका होना है ना.
Okay, okay, sir.
नहीं, वेगस का भी पूछते.
Like
Thank you,
mainly
thank you.
2, 3, 4, 6 and 5 and 7 are important. So rest all I'll cover the test, but
हाँ, जो भी
I'll
इम्पोर्टेंट
try
है.
to do that, sir. I'll split into 2 classes and try to cover that. Okay, then the class.